So my name is rather welcome to this segment of the Association of Future African Neurosurgeons Clinical Neuroanatomy Series. My name is Emmanuel Mukambo. I'm the Assistant Grants Development Officer of the Association of Future African Neurosurgeons, as well as a research fellow of the Association of Future African Neurosurgeons and a fifth year medical student at the Copperbelt University School of Medicine in Zambia. So on today's segment of the clinical neuroanatomy series, we'll be looking at the cranial nerves as well as different aspects. So without further ado, we'll go straight into my presentation. So this will consist the plan of my presentation today. We'll have the introduction, and then we'll discuss the course and anatomy of the cranial nerves, the functions of the cranial nerves, the signs of cranial nerve palsy, the clinical correlates, as well as the references of my presentation today. So the objectives of my presentation are to for the participants to know the course and anatomy of the cranial nerves, to understand the examination of cranial nerves, to know the features of the cranial nerve palsies, as well as to understand the presentation of cranial nerve dysfunction. So for today's presentation, we'll have specific. So there are primarily 12 cranial nerves. But for today's presentation, we'll look at specific, we'll tackle specific cranial nerves that are of major clinical importance. And yes, and those will be the major cranial nerves that we'll look at for today's presentation. So what are the cranial nerves? The cranial nerves are 12 paired nerves that are responsible for transmitting various motor, sensory, as well as autonomic stimuli between structures of the head and neck, as well as the thorax and abdomen. So most of these cranial nerves originate from the brainstem, with an exception of at least 3, which are the accessory cranial nerve, the olfactory cranial nerve, as well as the optic cranial nerve, strictly speaking, as we'll be able to see during the course of the presentation. So these cranial nerves are part of the peripheral nervous system, and they pass through various openings, which are called foramina or fissures, and they're called different names. And these openings within the bones of the skull allow for communication between components or structures of the intracranial cavity with structures that are outside the cavity. So all these nerves, except the 11th nerve, and the 11th nerve, the second nerve, as well as the first cranial nerve, have an origin from the brainstem. So these are differentiated. So the cranial nerves are also peripheral nerves, just like the spinal nerves are. However, the cranial nerves are specifically differentiated from the spinal nerves in that these nerves also tend to have a spatial sensory component, or special sensory functional aspects, as compared to the spinal nerves that generally have what are known as the general somatic afferent activity or function, as well as the general somatic efferent activity, as we'll be seeing, functional modalities we'll be seeing during the course of the presentation. So cranial nerves are classified based on different attributes. And one of these attributes is the functional basis. Yes, the functional aspect of the cranial nerves, which forms or rather constitutes the basis for classification of these cranial nerves. So, like I said initially, the cranial nerves are 12 in number, and they are paired. And so the first cranial nerve is the olfactory nerve, which has a specific function of smelling, and this is called the spatial sensory function, because the receptors for smell are specifically found in the olfactory mucosa or epithelium, and as a result, this is considered a spatial sensory function. In the same manner, we have the optic nerve, which is the second cranial nerve. It also has a spatial sensory function, and this function is the function of vision. We have the oculomotor nerve, which is a purely motor. Trochlear nerve is also purely motor, and these, together with the abducens nerve, are responsible primarily for movement of the eyes of the eyeballs within the orbit. We also have the trigeminal nerve, which is both sensory as well as motor, in that it supplies it is responsible for picking up and transmitting sensory information from components of the face, as well as some components within the oral cavity to the brain for processing. It also has a motor function, which it has a motor function by its innervation to the muscles of mastication. Yes. So continuing, the cranial nerves. We also have a cranial nerve number 7, which is the facial cranial nerve. The functional modality of the facial nerve is both sensory and motor. So it has a motor aspect that for its innervation to the muscles of expression, the facial muscles of facial expression, as well as a sensory aspect of taste on the anterior 2/3 of the. Okay. May the host kindly allow, or rather take up the role of admitting participants into the presentation. Thank you. Yes, so we have the facial cranial nerve, which also has a functional modality of both motor and sensory, and it is responsible for for innervating the muscles of facial expression, as well as taste in the anterior 2/3 of the tongue. We have the vestibulocochlear nerve, which is the 8th cranial nerve, has a special sensory function, which is to hear and balance. And it is, like I said initially, this is considered a special function because the receptors that are responsible for this activity are primarily found within the glossopharyngeal nerve, which is both sensory and motor, and is responsible, among many other things, for taste as well as the gag reflex. In addition to that, we have the vagus nerve, which is both motor and sensory, and just like the glossopharyngeal nerve, is responsible for various important reflexes such as the gag reflex, the vomiting and coughing reflex, among other things. In addition to this, the vagus nerve also sends parasympathetic innervation to structures within the thoracoabdominal cavity, such as the lungs, structures of the GIT, as well as the heart. The accessory nerve is purely motor, and this primarily sends its innervation or supplies motor innervation to muscles of the neck, specifically the sternocleidomastoid muscle, as well as the trapezius muscle. We have the hypoglossal nerve, which is important for speech as well as swallowing, and has a specific functional modality of. We'll discuss the course and anatomy as well as the clinical correlates of the cranial nerves. So, like I said initially, not all cranial nerves will be tackled in this presentation, but we'll tackle some cranial nerves of major clinical importance based on how much the presentation will give. So, the first cranial nerve we'll discuss is the olfactory nerve, which is the first cranial nerve, and it's a pair of sensory nerves whose origin is within the olfactory mucosa that is within the nasal cavity. So this olfactory mucosa is it lines the superior and posterior walls of the nasal cavity, and has specific cells which are known as the olfactory cells that send out nerve fibers within that pass, or rather communicate with the intracranial structures to the cribriform plate. So these foramina responsible for transmitting these axonal fibers, which are what are known as the olfactory nerve. So the olfactory nerve, like I said initially, has a special sensory function, meaning that it has a specific function, a specific sensory function, which is only conducted within this tissue, the olfactory mucosal tissue. So the specific function of the olfactory nerve is to confer the sense of smell. So it is one of the only two cranial nerves that has no direct association with the brainstem, and like I said, it originates extracranially. So in addition to this, it has the shortest intracranial course, starting within the nasal cavity, and yes, starting within the nasal cavity and extending into the cranial cavity through the foramina, like I said initially. So yes, so as we can see here, what we have here are what are known as the olfactory bulbs. So this is actually, yes, these are the olfactory bulbs, and this is the sorry. Yes, what you're seeing here are the olfactory bulbs and the olfactory tracts advancing or projecting from the olfactory bulbs. So just beneath the olfactory bulbs, what we have are the olfactory nerves coming from beneath. So these olfactory bulbs actually lie on the superior surface of the ethmoid bone on the cribriform plate. So separating the two is the crista galli, which is a vertical elevation of the ethmoid bone. So as we can see, as we can see here, what you're looking at is the anterior cranial fossa, or the superior view of the anterior cranial fossa, showing us the various openings on this bone. So the openings right there are the openings in the cribriform plate that allow for the communication of the olfactory nerves with the intracranial structures, specifically the olfactory bulb, and these project axons to various parts of the brain, such as the parahippocampal gyrus, as well as the entorhinal cortex, which are responsible for processing information associated with smell. So this is just another view that we can look at that shows the relationship of the olfactory tract, which is a component of the olfactory pathway, with other components of the central nervous system. So what we are looking at here is the optic chiasm, which we'll look at as we progress with the presentation. Okay, so for the olfactory nerve, the major clinical correlates that we can talk about are the clinical testing of the olfactory nerve. Considering the fact that the olfactory nerves has a specific sensory function of sensing, one of the best ways by which we can test the olfactory nerve is bringing a familiar odorant or a familiar smell to a patient, or rather to an individual we are testing, and then identifying if at all they're able to tell what the odorant they're smelling is. So the clinical conditions that are relevant under this include anosmia, hyposmia, which are basically reduction or loss of ability to smell. And this is associated with different conditions, with the differentials being conditions such as nasal polyps, viral upper respiratory tract infections such as COVID-19, chronic inflammatory sinus diseases, as well as frontal and occipital traumas to the skull base. And these associated with damage to, yes, these associated with damage to, it can either be to the olfactory bulb that is lying over the cribriform plate, or it can be due to the inferior primary olfactory cortices, such as areas like the parahippocampal gyrus, as well as the entorhinal gyrus, which are prominently lying on the base of the skull. So we also have hyperosmia, which is abnormally acute sensation of smells. So going on to the second cranial nerve, known as the optic nerve. So this is a nerve that is cylindrical in structure, if I can say, and it is purely sensory. So the optic nerve primarily conducts or transmits sensory information that is associated with vision, and it is structurally it is divided into 4 components. So there's an intraocular part, the intraorbital part, the intracanalicular part, and the intracranial part. So the intraocular part is the smallest part of it, which is approximately 1 millimeter, and it projects into the posterior aspect of the eyeball, where the optic nerve actually originates as axons of the retinal ganglion cells. So from the intraocular part, there's the intraorbital part, which is approximately 25 millimeters, and this is the longest part. And then we have the intracanalicular part, which is the part that falls or rather lies within the optic canal, and the intracranial part, which progresses and eventually forms the optic chiasm posteriorly. So like I said, the optic nerve, okay, sorry, I'll just take you to the next slide. So the optic nerve progresses or advances posteriorly, and at the level of the suprasellar area, it joins the left and the right optic nerves join to form the optic chiasm, which lies, as I said initially, over the suprasellar region, which has important clinical as well as surgical relevance. So what you're looking at in this picture is the posterior aspect of this is the point of the optic nerve that originates from the posterior aspect of the eyeball. So the view that we're looking at is the anterior view of the orbit, with the optic nerve being the structure that we can see. So the optic nerve in this case is right here, and what we are seeing around there are the extraocular muscles that are responsible for eye movements. And then this optic nerve projects, or rather advances posteriorly and medially, so that it passes into the optic canal and eventually gets into the intracranial space. So that's the course of the optic nerve. So it starts within the orbital space from the posterior aspect of the eyeball, projects, rather advances into the orbit, eventually into the optic canal, and finally into the intracranial space. So like I said initially, the optic nerve projects posteriorly, or rather backwards and medially, and first it passes to the orbital space and then into the optic canal, which is actually formed, which is an opening within the lesser wing of the, wing of the sphenoid bone. Yes, and what we are seeing here is just another view of the optic nerve. So this is a ventral surface of the brain, showing the optic chiasm and its relation with the circle of Willis within the suprasellar area. So this is the optic chiasm right there, and then that's the circle of Willis, right there. So clinically, one of the important components to discuss under this is the visual field defects. So just to give a brief background on this. So when we're looking at the optic pathway, we have nerves. We have the optic nerves that project all the way from the anterior aspect, or rather the posterior aspect of the eyeball, and collect information from the visual fields, and project this sensory information backwards. However, as the optic nerves are advancing posteriorly, we have nerves that come from the, so this side is, these fibers, so like they're divided into two. These fibers are referred to as the temporal, the fibers from the temporal retina, and these are the fibers from the nasal retina. So the fibers from the nasal retina on both sides decussate when they reach the optic chiasm, such that we have optic fibers of the nasal retina from the right side going over to the left side, and the same is the case with the nasal optic fibers on the right side in this case. So the right side and the left side in that case. So this decussation allows for us to understand the clinical correlations or the clinical signs and symptoms that patients may present with when it comes to issues of visual field defects. So visual field defects are a result of different conditions, with one of the commonest being multiple sclerosis, as well as conditions such as compression of the optic chiasm at the suprasellar area by pituitary adenomas. So there's a sudden presentation of visual deficits, which points towards ischemic, demyelinating, or traumatic etiologies. And then progressive deficit is usually indicative of conditions that could be infiltrative or compressive, such as pituitary adenomas, as I mentioned initially. So as you can see here, we have various presentations, or rather various complaints that the patient would bring up or raise, depending on where the lesion actually is. So if the lesion is at point A, what we would have is a central scotoma. If the lesion is at B, would have a monocular vision loss, complete monocular vision loss. If it is at the level of the bitemporal or at the level of the optic chiasm, would have temporal hemianopia, and so on and so forth, as we can see in the slide. And these presentations are primarily based on the concept of decussation. So at this level, for example, when you look at bitemporal hemianopia, which is this right here, the reason why we're having this is because of the issue of decussation, where we have so in this case, for example, if we have a lesion, or that is a lesion, or maybe a discontinuity in the nerve at B, what would have is that the patient would not be receiving visual information in this field, in this aspect of the visual field, as well as this aspect of the visual field, and as a result, information being taken to being received in the primary visual cortex would be incomplete, and what we'll be having is a loss of perception of light, which is the stimulus for vision in this case on the nasal retina. The nasal visual field. The temporal visual field. Sorry, temporal visual field in that case. So moving forward, we have the third cranial nerve, which is the oculomotor nerve. So this nerve is primarily motor, though it has a parasympathetic division to it. So it emerges from the interpeduncular fossa, which is just an area in the midbrain, the superior colliculus. So what you're looking at here is the midbrain, and this right here is the interpeduncular fossa. And this is these are the third cranial nerves, the oculomotor nerves, projecting right from the interpeduncular fossa, projecting towards the superior orbital fissure to eventually reach the eyeballs. So from the ventral midbrain, it courses anteriorly as well as on the lateral aspects, on the lateral wall of the cavernous sinus, and eventually enters into the superior orbital fissure to get into the orbit. So as it enters into the superior orbital fissure, the oculomotor nerve divides into two branches. So there's an inferior branch as well as the superior branch. So the superior branch specifically innervates the levator palpebrae superioris, which is the muscle that's responsible for retraction and elevation of the upper eyelids, as well as innervation of the superior rectus muscle. The other branch, which is the inferior branch, is responsible for innervation of all the other extraocular muscles that are primarily innervated by the oculomotor nerve, which include the major rectus muscle, the inferior rectus muscle. Yes, those, as well as it also has a parasympathetic division, which is carried by the inferior branch, and it synapses within the ciliary ganglion, and this is responsible for sending supply to the ciliary muscle for visual accommodation, as well as to the muscles within the pupil for that is responsible for pupillary response in response to light. So with regards to clinical correlates, what we are looking at here is ophthalmoplegia as a result of oculomotor nerve palsy. So in this individual, what we are looking at, in these two individuals, we are looking at external as well as internal ophthalmoplegia. So external ophthalmoplegia is a paralysis of the extrinsic muscles as well as the levator superioris that leads to deviation of the ipsilateral eye to the lateral side. So what you're looking at here, there's a defect in the cranium, in the left oculomotor nerve, as we can see in this patient. So there's a sort of drooping of drooping of the upper eyelids with with deviation of the eyeball to the left side. So this is as a result of an opposed lateral pulling or lateral effect that the unopposed abducens nerve, as we are going to see, has in this case. So there's the ability for this patient to actually have their eyeball point straight ahead is because of the balance between the lateral and the medial rectus muscles. However, the medial rectus muscle in this case is unable to hold the to apply the medial force, and as a result, we have an opposed pull to the lateral. We have this patient where we can see that there's an irresponsive pupil on the left. So in this case, there's paralysis of the intrinsic muscles leading to a permanent dilatation of the pupil. So we remember that the oculomotor nerve also has a parasympathetic supply. So in this case, there's a defect in this nerve, which is responsible for supplying parasympathetic fibers to the pupil, and as a result, there's dilatation and lack of response by the pupil to light. This is the fourth cranial nerve, which is the trochlear nerve. It arises from the midbrain, just inferior to where the third cranial nerve arises from. So this is still the interpeduncular fossa that we are talking about, but then just inferior to the level of emergence of the third cranial nerve. So, like I said initially, the third cranial nerve arises at the level of the superior colliculus. So the fourth cranial nerve actually arises from beneath. So one important thing that is worth noting here is the fact that the trochlear nerve actually has is special in that it actually emerges posteriorly on the posterior aspect of the posterior aspect of the midbrain. I think I mentioned something concerning it coming from the interpeduncular fossa. It doesn't. So it comes from the posterior aspect of the midbrain and courses anteriorly, and as a result, it is the cranial nerve with the longest intracranial course. And this actually has a clinical relevance in that it is actually more prone to be damaged because of its long intracranial course. Where function is concerned, the trochlear nerve has a specific motor function, and this is responsible for supplying motor function. Yes, it is responsible for supplying motor fibers rather to the superior oblique muscle that is responsible for rotating the eye outwards as well as downwards. So what we're looking at here is an animation of the trochlear nerve. So like I said initially, it arises from the trochlear nucleus and runs up at the back of the midbrain. But then this is still at the level of the inferior colliculus, which is inferior to the site of emergence of the oculomotor nerve. So we have the trochlear nerve going like that, and then supplying the superior oblique muscle right here, as we can see. So just like the oculomotor nerve, this nerve also exists, or rather exits the intracranial cavity via the superior orbital fissure. Okay. What we're looking at here is a patient who has a palsy of the trochlear nerve. So in this patient, what we can see is that there's a defect with the right eye where it is intorted, so it goes upwards. Yes, it is directed upwards and medially. So this is because the trochlear nerve initially is supposed to pull the eyeball downwards and laterally. So because of this palsy, there's an unopposed function of the superior rectus muscle that is supplied by the oculomotor nerve, which in this case is intact. So there's a diplopia that is due to weakness, and that is due to weakness of the muscle that is supposed to oppose this motion in that direction. So the commonest cause of vertical diplopia and patient compensates by tilting the head towards the affected side. What you have here is the fifth cranial nerve, the trigeminal nerve, which emerges from the pons at the junction of the middle cerebellar peduncle, and it does so by two routes. So the trigeminal nerve has both a sensory aspect, so we can say it is a mixed nerve in that it has a sensory aspect as well as a motor aspect. So the sensory aspect of it is that it sends fibers that rather it has fibers that project and that project towards the brain while carrying sensory information from the various aspects of the face and the scalp. It also has a motor function, rather as a it has a motor function which supplies or innervates the muscles of mastication, specifically in this case the temporalis muscle, the masseter, the lateral and the medial pterygoid muscles, which are responsible for mastication. So what we're looking at here is the trigeminal nerve. So the trigeminal nerve, as it is emerging, rather advancing from the brainstem, it reaches a level, rather an area within a part of the temporal bone, the precursor part of the temporal bone, in a depression known as the trigeminal groove, where it forms the trigeminal ganglion. So this, from the trigeminal ganglion, we have the trigeminal nerve dividing into three divisions, with the upper one or the superior one being the ophthalmic branch, and the middle one being the maxillary branch of the maxillary nerve, and the inferior one being the mandibular branch. The mandibular branch is special in because it also carries with it a motor root, a motor root which eventually supplies the muscles of mastication that I'd mentioned. So that's basically that. So with regards to exiting the cranial cavity, then the ophthalmic branch exits the cranial cavity to the superior orbital fissure, just like the oculomotor nerve and the trochlear nerve, while the maxillary branch exits via the foramen rotundum, and the mandibular branch exits via the foramen ovale. So this just shows the branches of the trigeminal nerve and where they supply. So we're looking at the superior branches, which is the ophthalmic nerve, and this is responsible for supplying sensory innervation to aspects of the face and the skull that are above the palpebral fissure, which is here. That's a palpebral fissure, as well as areas around the eye and portions of the nasal cavity. We also have a maxillary innervation, which is around portions of the nasal cavity, sinuses, the maxillary teeth of the palate, and the middle portion of the face and skull that above the mouth and the head and the forehead. And then the mandibular portion, like I said, is both sensory and motor, as it carries the motor root along with the mandibular branch, the mandibular sensory branch. Okay. So with regards to clinical correlates, the patient who's experiencing a trigeminal nerve palsy may complain of issues such as raise complaints of ipsilateral loss of sensation in areas of distribution. So if there's a disruption in the functionality of the cranial nerve on the left side, the patient will most likely complain of loss of sensation on the left side of the face, because that's a part where this trigeminal branch or the trigeminal nerve proper itself is responsible for supplying. We also have there's also a loss of sneezing as well as blinking reflex. So this is important to note because, for example, the blinking reflex is under the influence of two nerves, actually, the facial nerve as well as the facial nerve as well as the trigeminal nerve, with the facial nerve conferring a motor activity or a motor response in the reflex, as the trigeminal nerve confers a sensory functionality to this reflex by, say, stimulating by stimulating the cornea, say with cotton wool, and this would stimulate the blinking reflex or the corneal reflex. We also have trigeminal neuralgia, which is an important clinical correlate, which is characterized by paroxysmal episodes of intense pain within the eyes, lips, nose, scalp, as well as the forehead and jaw of the ipsilateral side, where the trigeminal nerve has actually been disrupted, where functionality is concerned. And then the condition is not easily treated, and the last resort for treatment is actually severing the trigeminal branch that supplies the area that is associated with the pain that the patient raises as a complaint. We also have the 60th cranial nerve, which is the abducens nerve. So this, together with the oculomotor and the trochlear nerve, is responsible for supplying the extraocular muscles. They're supplying the extraocular muscles that keep that control the gaze of the eye. So it arises from the pontomedullary junction, which is the junction of the pons in the medulla, and it exits the cranial cavity via the supraorbital fissure, just like the other nerves we've discussed prior to this. So it is responsible for innervating the lateral rectus muscle, meaning that a palsy of the abducens nerve will result in the patient presenting with an eyeball that has a medial strabismus, meaning that the eyeball actually deviates or defects or deflects towards the medial aspect of the face. So it is responsible for eyeball abduction, meaning it is responsible for deviating or deflecting the eyeball from the midline, and it has specifically a motor function. So what you're looking at here is a patient who has an abducens nerve palsy. So there's inability of the patient to look laterally on the left eye, and this eye is deviated medially, as we're able to see, because of the unopposed action of the medial rectus muscle, which is supplied specifically by the inferior branch of the oculomotor nerve. So this nerve, just like the trochlear nerve, is also highly susceptible to damage because of its long intracranial course, and damage leads, just like the trochlear nerve, also leads to diplopia and medial strabismus, as we are able to see in this patient here. So the abducens nerve is also responsible, it also assists with controlling or rather coordinating the head movement with the eye movement, so that when the head is tilted, the eyeball is still kept in its place. Okay, the 7th nerve we'll look at here is the facial cranial nerve. So the facial nerve is described as the most complex. So we said the trigeminal nerve is the largest nerve. The cranial nerve is the most complex nerve because of its branches and the supply that is associated with it. So this nerve, just like so this nerve also originates from the pontomedullary junction, just like the abducens nerve that we've just described. So an important thing to notice is that the pontomedullary junction is a common place for infected tumors, and it does originate by two routes. So it's important to also note the fact that the facial nerve is both motor and sensory. So as it is emerging at the pontomedullary junction, there's a medial route as well as a lateral route, with the medial route containing motor fibers that are responsible for innervating the the muscles of facial expression, and the lateral route, which is responsible for parasympathetic supply to all the glands within the head, and most of the glands, you can say, within the head and the neck, except the parotid gland. It also has an aspect of spatial sensory fibers that are responsible for detecting taste in the anterior tooth of the tongue. So this nerve passes through the internal acoustic meatus together with the vestibulocochlear nerve, which eventually, and the vestibulocochlear nerve eventually passes to the ear, where it runs, or rather, where it runs in the facial canal. That's specifically the facial nerve. So it exits the cranium via the stylomastoid foramen, and it enters the parotid gland, but does not supply it. This is actually a very common, a very famous feature of the facial nerve, that it enters or pierces the parotid gland without actually supplying it, but supplies every other gland within the head and the neck. So these glands include the lacrimal glands, the nasal glands, the palatine glands, as well as the salivary glands, specifically the sublingual and the submandibular glands. So, okay, yes, I think that's basically everything on that. So what we are looking at here are just the various branches of the facial nerve. So I think the nerves worth noting here are these branches, the terminal branches of the facial nerve. So as the facial nerve is coursing and coming all the way from the pontomedullary junction, it has various nerves that it sends out, which are branches like the greater petrosal nerve, as well as other nerves. But then the terminal branches that it actually gives out are the temporal zygomatic, buccal, marginal mandibular, as well as the cervical branches. So that's the cervical branch. Okay. What we're looking at here is simply the branches of the facial nerve. So we have the greater petrosal nerve, which is actually the first branch of the facial nerve as it is exiting the intracranial cavity coming from the superior ganglion of the facial nerve. We also have the nerve to the stapedius. We have the chordae tympani nerve. We have the posterior auricular nerve. We have the nerve to the posterior belly of the digastric. The temporal, zygomatic, buccal, and marginal mandibular and cervical branches. So it is important to note that the greater petrosal nerve is the nerve that is responsible for supplying secretomotor fibers to the lacrimal glands as well as the palatine glands. The nerve to the stapedius is responsible for supplying the muscles of the stapedius muscles, while the chordae tympani nerve is responsible for supplying the anterior two-thirds of the tongue and is responsible for the taste, the taste function of the functional nerve, of the facial nerve, sorry, and also supplies secretomotor fibers to the submandibular and sublingual glands. There's also a posterior auricular nerve which supplies the occipital belly of the occipital temporalis and auricular muscles. We have the nerve to the posterior belly of the digastric and stylohyoid muscles, which are accessory muscles of mastication, if I can say. Okay, so clinical correlates. So one of the most important clinical correlates of facial nerve palsy is Bell's palsy. So Bell's palsy is basically a condition that arises from an injury in the lower motor neuron of the facial nerve pathway. So I'll just take you briefly to the next slide so that I'm able to explain this better. So what we're looking at here, we have this entire pathway is the facial nerve pathway. So in this pathway, we have lower motor neurons as well as upper motor neurons. The lower motor neurons arise from the nuclei of the facial nerve, which are within the brainstem. And then we also have the upper motor neuron, also known as the corticobulbar neurons that are responsible for supplying, for sending regulatory impulses or action potentials to this nuclei. So if we can look closely here, we have a situation where, say, when we focus on these nuclei, we have these nuclei that are receiving tracts, corticobulbar tracts, from this end of that are receiving tracts from the ipsilateral side as well as the contralateral side. So there's a contralateral supply to these nuclei as well as ipsilateral supply to this area. So what is special about this is that Bell's palsy is a palsy of the facial nerve that arises from a lower motor lesion. So in this case, when we have such a situation, you find that this individual will have paralysis of the entire face. However, in a situation where the dysfunction in this pathway is due to, say, an individual who has a stroke, and the dysfunction and there's an inability of these nerves to actually pick up potential from here, this patient will have retained functionality within the superior aspect of the face because of the lower motor neuron tracts, which still receive I don't know if I can say information or action potentials from the ipsilateral side. So that's one. I think that's briefly how I can explain how facial nerve palsy arising from a lower motor neuron is differentiated from the facial nerve palsy that arises from an upper motor neuron. So this is just another illustration of it. So lesions that are below the facial nerve, facial nerve nucleus at the level of the brainstem are called lower motor neuron lesions or palsies. So those palsies specifically for a neurological condition that is characterized by a sudden onset of paralysis on the ipsilateral side of on the ipsilateral upper and lower part of the face, on which the nerve has actually been destroyed, and it may result as a result of degenerative conditions, inflammatory conditions, or it can actually be due to traumatic conditions or conditions like infectious conditions such as mumps. Since we remember that the cranial nerve has the facial cranial nerve has a route through the parotid gland, and that may be associated with that. So signs and symptoms include affected saliva secretion, absence of corneal reflex, which we talked about under the trigeminal aspect. We also have loss of taste in the anterior two-thirds of the tongue. So with regards to the vagus nerve, so it is the longest cranial nerve, which with extension all the way to the thoracoabdominal viscera and components. So it leaves the skull through the jugular foramen, and it occupies the posterior aspect of the carotid sheath as it descends down to the thorax and eventually the abdomen. So it does so when it is within the carotid sheath. It descends within it descends between the jugular vein and the internal common carotid artery. So the vagus nerve runs down, advances inferiorly to the neck and eventually to the prevertebral muscles and fascia. And then as it is descending, the internal jugular vein lies behind, while the internal common carotid artery, like I said, lies anteriorly. Okay. So with regards to its origin in relation to the brainstem, it arises from the postsalivary sulcus within the medulla oblongata. So the functions of the cranial nerve, of the 10th cranial nerve, include general sensory. It sends out, it receives rather it transmits general sensory fibers from the external ear as well as the surrounding areas such as the pharynx, the larynx, the esophagus, the trachea, the heart, as well as the abdominal and thoracic viscera, like the lungs. So it also has motor fibers from the voluntary muscles of the pharynx and most of the larynx and as well as the soft palate, and parasympathetic fibers to smooth muscles and glands. So smooth muscles such as components of the foregut. So it is also involved in important reflexes such as the cough reflex, the gag reflex, the vomiting reflex, the sneezing reflex, as well as the swallowing reflex. So in summary, I just have a number of tables here that summarize the functions as well as the origins and the names of the cranial nerves that we've discussed in this lecture. So for the cranial nerves that we have not discussed, the necessary threshold information has been provided in this summary in the tables I've outlined. So this marks the end of my presentation. Thank you very much for your time.
Yeah, thank you so much, Emmanuel, for that wonderful presentation. I would say the presentation was amazing.
Okay, I don't know if we're able to get Benisha, but I think I would like to acknowledge the presence of Dr. Kabulo in our midst. Dr. Kabulo, are there any remarks that you may have for the presentation?
Thank you so much, Emmanuel, and congratulations for that fantastic presentation. That was very, very good, and you managed to summarize major features of those cranial nerves. So I joined a little bit later, but I enjoyed because it was a good summary. Maybe next time they will try to divide this presentation in several topics. So I mean, if someone can get 3 cranial nerves, another one 3, so we try to go very, very deep, especially about clinical correlations. So I really enjoyed, and I wanted just to add one thing about cranial nerve number 6 and cranial nerve number 7. Cranial nerve number 7 is the most injured nerve when you have basal skull fracture. And there is a classification, a clinical classification, Breck-Hausman classification, where you are grading that paralysis into grade 1, grade 2, up to grade 6. So when you get basal skull fracture, it's always important to look for cranial nerve number 7 palsy. Of course, number 8 also, but the number 7 because it has a long course in the bone. And also about cranial nerve number 6. The 6th and 4th, the diplopia is, the patient may not have diplopia when they have cranial nerve number 4 palsy. They may or they may not have it. And if they have it, it's a vertical one, vertical diplopia. And usually when you are reading, the patient who has cranial nerve number 6 palsy, he can't read a book and he can't go downstairs because when trying to go down, he can't sit down, and usually they have blurry vision. That blurry vision prevent them to read a book which is on their hands because they can't look downwards and laterally. And also when they are going downstairs, it's also very difficult. They might have diplopia, but diplopia is most seen when you have cranial nerve number 6 palsy. There you have, especially when you have cranial traumatic brain injury, the first nerve to be injured is the cranial nerve number 6, because when you give intracranial pressure, there is a downward displacement of the posterior fossa. You know, up in the supratentorial space, there's a increased pressure, so it pushes the brainstem down, and the brainstem stretches the cranial nerve number 6. Remember, the cranial nerve number 6, when it is going, it is attached to the apex of the petrous bone, of the petrous part of the temporal bone. So that nerve is stretches, and you get diplopia, you get 6th nerve palsy, especially in head injury patient. That's why when you are examining the patient with head injury, there are specific nerves you have to look at. Like number 3, you have to check your parasympathetic, which is around the cranial nerve number 3, which is around the cranial nerve number 3. When the cranial nerve number 3 is compressed, so it's the parasympathetic part which started to be affected, because it's around, the parasympathetic is around the cranial nerve number 3. And you get blown pupil. After that, I'm sorry, after that, there is a cranial nerve number 2. You have to check for vision. You have to check for the cranial nerve number 6, especially 6 in case of a head injury, like I mentioned the mechanism. And also cranial nerve number 7, I mentioned because of if there's a skull base fracture. Cranial nerve number 7, number 9 and 10, you have to check for gag reflex, especially in case of cerebral brain death. When you get brain death, you are now examining those reflexes. In head injury, you have to check for cranial nerve number 9 for gag reflex. You stimulate. If the patient is intubated, just try to pull the tube. When you are pulling, it will irritate the posterior pharynx, and you get the patient to have like vomiting reflex. He will be like trying to vomit. And 5 and 7 for corneal reflex, like all of you, the corneal reflex, when you stimulate the sclera, the white part of the eye, and the patient will blink. So that's what I wanted just to add in terms of clinical correlations in head injury patient, because head injury, everyone must know about head injury. Those are the cases we get on a daily basis. Every day we get patient with the head injury. So those cranial nerves, you have to check for them. Thank you so much again, Emmanuel, for that good presentation. Thank you everyone for coming.
Thank you very much, Dr. Paul. Benisha, over to you.
So I don't know, since Benisha is like having some difficulties. I don't know. Is there any question? Is there any comments? Anyone?
I have a question on the presentation regarding Bell's palsy and stroke.
Please go ahead.
I don't know if Emmanuel could help us by giving us the diagram that he had shown before. I think that was slide 21. Okay, just as he's also going to the slide, is there a relationship between the upper motor neurons and the lower motor neurons? Like, do the lower motor neurons need to receive impulses from the upper neurons to work first before they can act on the various parts of the body? Before I ask my question, maybe I think this question can be answered.
Well, I don't know, before maybe others can answer. So there's, from what I read, there's actually two aspects with regards to the motor activity for the muscles of facial expression. So we know that for the voluntary muscles, we have influence from the brain by either the corticobulbar tracts or the corticospinal tracts. So the corticospinal tracts are the tracts that eventually sends the motor regulatory fibers to the muscles within the limbs as well as the torso. However, with regards to the facial nerve pathway, like I mentioned, so we have an input from the corticobulbar tract, which is like a voluntary aspect of it, and then there was from what I came across, there's an input from say the hippocampus. There's an input into the nuclei of the facial nuclei of the facial nerve. We have input from the hippocampus, as well as other cortical structures that are responsible for involuntary expression, facial expressions. For example, those that are related with emotions. So it is both voluntary and involuntary.
Okay, thank you. And then on slide 1, anyways, my question is, why is it that in a patient presenting with stroke, their forehead is spared, but in a patient presenting with Bell's palsy, there is a defect also in forehead muscles? Because on slide 21, it shows that, I don't know if you can refer us to slide 21 so that I can explain properly.
This is slide 21.
Oh, it's showing slide.
Did you mean this slide?
Okay, yes, this is the slide. Yes, because also in the, okay, before I continue, was the second diagram illustrating a patient with stroke?
There's the one on the left has Bell's palsy, and then the one on the right has stroke with the forehead muscle sparing.
Or then on slide 21?
This one?
Yes. Are
Yes,
they
so
both
the
for, one is for
so-
stroke?
Yes, the one on the right has a supranuclear lesion, so which means there's, for example, there's a lesion in the the precentral gyrus.
Okay, so from what we have seen here is like the neurons are also, they're originating from the corticobulbar area, as you had explained. So why is it that in a stroke patient, the forehead muscles are not affected? In Bell's palsy, the forehead muscles are affected.
Okay, so the reason is because we have like different nuclei for the facial nerve. So there are nuclei that projects motor fibers to the inferior component of the face, and then there are also this nucleus that sends innervation to the upper portion of the face. So what we have in this case is that these nuclei are also supplied by motor fibers from from contralateral and ipsilateral side. So in this case, if you have a situation where so okay, what I don't know how I'm supposed to say this, but what this implies that we have the nuclei in this case are receiving information from both sides of the precentral gyrus. So this implies that if you have a lesion that and these fibers actually synapse with these lower motor neurons. However, the lower motor neurons that supply the lower half are not only receive information from a contralateral side. However, the fibers that innervate the upper half receive information from the contralateral as well as the ipsilateral side. So this simply means that if there's a lesion in this aspect, the lower motor neuron will be the lower motor neuron that supplies the lower half will be affected because it is not receiving a compensatory, like a bundle of fibers from the ipsilateral side. However, the fibers that innervate the upper portion of the face are receiving information from both the left as well as the right. So if the left is in this case is has a lesion of sorts, that simply means the right side will still compensate. So in short, what this simply means is that the lower motor neurons that supply the lower half do not receive from both sides, meaning there's no compensation once there's a lesion in that side, which is the contralateral side. However, the upper half has fibers from both the contralateral as well as the ipsilateral side. So if there's a defect in this side, that simply means in this case in the left side, that simply means the fibers on the right side will compensate for the fibers that are not working in that case. I don't know if you get my.
Yes, I have. Thank you so much.
Can I add something there?
Yes, please.
Can I add something?
Yes, please.
Okay, thank you, Emmanuel, for that explanation. That's correct. So for our sister who asked the question, it doesn't mean just check properly those fibers. You said why those patients who are having stroke, the upper part is not affected. In clinical situation, we always teach students like that the upper part is spared, but actually it's not spared. That part is affected, but it's weak because the other side is compensating. But those fibers going to the lower part, they receive only, they are not crossing, they're coming from one side and they're affected, the mouth is deviated, but the upper part is affected, but both sides, it's 50%. Just check the diagram. From one side, there's 50% of fibers going to the contralateral nucleus, and 50% going to the ipsilateral nucleus, which means those fibers are going to the upper part. When they are affected, both sides are affected, but weak, because the other side is compensating. There is also 50% coming from the contralateral side. But clinically, we always teach, telling students that the upper part is spared when you get upper motor neuron, but it's not really. It's not that the upper part is not affected. It is affected, but in 50% both sides. So it is affected, but weak, not like the normal one. If I ask you to look upward, so you see those lines coming from your forehead, but if you have stroke, you get them, but not stronger than the normal person. So the part is affected, but in 50%. I don't know if you get that one.
Yes, it's clear.
Yes. Yes, thank you.
Thank you very much.
Thank you very much for the interactions. I don't know, any other question or comments or any other addition to the presentation, please? Okay, so since no one is talking, I'll assume everything was well understood. Please feel free to, if you have any questions, maybe you encounter a patient, you have difficulties, please, if you're in the group, give a comment there. We'll always answer to you. In case you maybe have any topic that you think is important for you to present at AFAN, please feel free to mention it in the group so that we'll see how we can arrange for you to present or any other thing. Thank you very much for creating out your time.
I will just my final word. I'll just recommend all of us to read De Jong. Anyone can go through the cranial nerves again on De Jong. It is more detailed there. So De Jong, the central nervous system examination. De Jong. Thank you.
Okay, thank you very much, Dr. Kabulo. Thank you, Bye bye. Take care.